Good morning, my name is April, and this is my presentation on improving the CDC's National Asthma Control Program via REAIM framework. Asthma in the United States is both common and costly. According to the Center for Disease Control and Prevention, in 2016, nearly 26 million Americans, including 7.1 million children, have asthma, concluding 1 in 13 individuals have the chronic respiratory disease. In the United States, 50% of adults with asthma and 40% of children have asthma do not have control over their disease, accounting for approximately 439,000 hospitalizations, 1.6 million emergency department visits, 10.5 million physician office visits, 13.8 million missed school days, and 14.2 million missed workdays. 40% of those episodes are triggered by preventable at-home hazards such as smoking, mold, dust, mites, pests, combustion products, and chemical irritants. This comes out to a total of $62.8 billion annually for treatment and $50 billion in healthcare costs. And finally, the mortality rates. Although the rate of asthma deaths decreased from 15 per million in 2001 to 10 per million in 2016, females still have higher death rates, and non-Hispanic blacks were 2 to 3 times more likely to die from asthma compared with the other race groups, non-Hispanic white and non-Hispanic other, as well as Hispanics. Among children, boys and non-Hispanic blacks were more likely to die from asthma. The same is true for adults. The CDC's National Asthma Control Program, or NACP, came to fruition in 1999 to help millions of people with asthma in the United States gain control over their disease. Through conducting national asthma surveillance and funding states to help them improve their asthma surveillance and to focus efforts and resources where they are needed. NACP goals were to reduce the number of deaths, hospitalizations, emergency department visits, school days or work days missed, and limitations on activity due to asthma. Inadvertently, the program actually improved the quality of asthma care, improved asthma management in schools, and foster policies to help reduce air pollution and ultimately reduce the cost and gain control over the disease. What is a REAIM framework, or Reach Effectiveness, Adoption, Implementation, and Maintenance, can be used as a tool to evaluate planning and the evaluation framework to measure different aspects of the public health intervention within a program such as CDC's NACP, which is a program vital for asthma education, prevention, and research. Since their development in 1999, millions of Americans to this day have benefited from the program, and asthma mortality rates have decreased by more than 45%. Reach from the framework can be defined as the absolute number, proportion, and representativeness of individuals who are willing to participate in a given initiative, intervention, or program. One might ask oneself, who is or was intended to benefit and who actually participates or is exposed to the intervention? Next up, we have effectiveness or efficiency. It can be defined as the impact of an intervention on important outcomes, including potential negative effects, quality of life, or economic outcomes. Think about what is or was the most important benefit you are trying to achieve, and what is or was the likelihood of negative outcomes. Adoption can be defined as the absolute number, proportion, and representativeness of settings and intervention agents who are willing to initiate a program. Now, let's think about how I can deliver the intentional support to deliver my intervention for the program. Also, where is or was the program or policy applied, and who applied it? Implementation or consistency can be defined as the cost and adaptation made during the delivery is the intervention agent's fidelity to the various elements of an intervention's protocol, including the consistency of delivery as intended and the time and cost of the intervention. At the individual level, implementation refers to the client's use of the intervention strategies. Asking a sequence of an individual's questions, such as how consistently is or was the program or policy delivered, how will or was it adopted, how much did or will it cost, or why will or did the results come about. Finally, maintenance or sustainment is the extent to which a program or policy becomes institutionalized or part of a routine organizational practice and policies within the REAIM framework. Maintenance also applies at the individual level. At the individual level, maintenance has been defined as the long-term effects of a program on outcomes after 6 or more months after the most recent intervention contact. I can now ask myself, when will the initiative become operational? How will it be sustained? And how long are the results sustained for? For more information, please don't hesitate to go on to their website. These are their websites, contents at a glance for details regarding the information we went over on the aforementioned slides. Now to begin applying the framework to NACP, but first, a timeline of the program. National Asthma Control Program began in 1999. The Center for Disease Control and Prevention created the program to help fund states with the goal to reduce the number of deaths and hospitalization, and etc. The program's development supported the goal and objectives of Healthy People 2010, tracking interventions and partnerships. Fast forwarding to 2001, NACP funded 13 asthma projects, 45 asthma interventions, and 30 asthma partnership projects. In 2002, in the Inner City Asthma Intervention, the NACP funded 23 sites in 15 states to prove inner city families with asthma education and individual asthma control plans. In 2005, the Asthma Callback Survey was implemented in conjunction with BRFSS. In 2007, the National Surveillance for Asthma published national data on asthma for self-reported prevalence. Between the years 2009 to 2014, the program expanded to 36 states and territories. And in 2010, the NACP published the first Learning and Growing Through Evaluation. In 2012, CDC and other agencies coordinated federal action plan to reduce racial and ethnic asthma disparities as part of the President's Task Force on Environment, Health Risk, and Safety Risk to Children to identify environmental health and safety risks to children. In 2001 to 2010, NACP publishes National Surveillance of Asthma Reported Detailed Trends in Asthma Prevalence, Healthcare Use, and Mortality. 3 years later, Asthma Stats Fact Sheet is published, containing brief facts on different surveillance topics. In 2014 and 2016, NACP Healthcare collaborates for people with poorly controlled asthma. It provides or links to more individual services. In addition, a second edition of Learning and Growing Through Evaluation is published. In 2016, the Asthma Callback Survey expands. And lastly, in 2018, NACP developed a set of 6 strategies. Exhale, or education distinguishing home, achievement, linkages, and environmental. Each contributes to better asthma control. In the form of a logic model, NACP is displayed as a hypothesized chain of cause and effects. Today's decrease of 45% asthma mortality is also today's increase in asthma control. Ultimately, as a result of increased asthma control, we are decreasing healthcare costs through the stages of asthma education, prevention, and research. Applying REAIM model is a helpful framework to assess the National Asthma Control Program. Who is NACP reaching? Target populations are individuals with poorly controlled asthma within 25 states and 3 GWOs in the United States. The program selected 600 participants from randomized states such as Michigan, Montana, and Rhode Island in 2016. Effectiveness. Since it started in 1999, asthma-related deaths have gone down by 41%, even though the number of people with asthma has gone up since then. Adoption. NACP reached out to hospitals, schools, and etc. to develop partnerships to survey those with the chronic disease. Implementation. Controlling asthma in the U.S. over the last 12 years, costs due to the asthma illness and deaths have decreased by $23.1 billion, representing an estimated return on investment of $71 saved for each dollar spent. And finally, maintenance or sustainment. Millions have benefited from the program, and asthma mortality rates have decreased by more than 45%. The program needs funding to continue to be effective within our communities as it works to decrease the number of emergency visits, hospitalizations, and deaths caused by asthma each year. Reach. Low-income populations, minorities, and children living in inner cities visit the emergency department more often and more likely to be hospitalized or die due to asthma. An estimated 62,000 children on Long Island suffer from asthma. Targeting children aged 0 to 4 years, ACLI trained 175 student nurses to educate 1,407 child care and Head Start providers, each of whom cares for 20 children daily. In addition, the NACP provides funding to Controlling Asthma in American City Projects, a locally based collaborative in 7 cities, including New York. CAACP's goal was to develop comprehensive, culturally appropriate, localized asthma control plans targeting children ages 0 to 18 years in inner city areas with large, unmet asthma control needs. Although the project ended in 2008, Several CAACP sites have secured their own funding to sustain the efforts launched in 2002. Effectiveness. 1 in 11 children and 1 in 12 adults had asthma in 2010. Black children were twice as likely to have asthma as white children. Also, low-income population, minorities, and children living in inner cities visit the emergency department more often, also more likely to be hospitalized or die due to asthma. By working with state health departments on community-based care models, the NACP have been able to reduce the number of deaths, hospital stays, and emergency department visits. In fact, since starting up in 1999, the asthma-related deaths have gone down by 41%, even though the number of people with asthma has gone up since then. CDC promotes collaboration by actively recruiting and engaging both internal and external partners. As mentioned before, partners may include other programs within state health departments, state and local asthma coalitions, healthcare plans and providers, advocacy organizations, and other CDC-funded initiatives. State asthma control programs have significantly broadened the search of their services by forming sustainable partnerships with other agencies and organizations committed to reducing the burden of asthma. For example, one of NACP's success stories comes from Rhode Island's HARP program. For higher utilizers, ED and hospital costs decreased by 80%, an average of $2,780 per person over the following year. Among high utilizers, return on investment was 2.26 per $1 spent. In conclusion, the CDC's NACP is vital to state asthma control programs, having significant impact towards asthma burdens. Through education, prevention, and research, we are then lowering the mortality rates of these children. Implementation. During the last funding cycle in fiscal year 2021, Congress did not increase the funding of NACP. This left the program flat funded at $31 million. Flat funding means the program received the same funding from Congress as the previous fiscal year. The House and Senate are now working on the funding for fiscal year 2022. The Asthma and Allergy Foundation of America is urging the Congress to include $34 million for the NACP program. $34 million was approved last year by the House. Although this won't give NACP national reach, it's a start. The extra $3 million will allow the NACP to fund an extra 2 or 3 states and improve asthma surveillance. The CDC currently doesn't have complete surveillance data for asthma nationwide. This makes it difficult to compare statistics across states, cities, and territories. The CDC requires funded state asthma programs to identify and document the goal, objectives, and strategies needed to reduce the burden of asthma. Initially, by 2006, the New York State Department of Health had established 11 regional asthma coalitions, reaching almost all countries' high-risk neighborhoods. The program results after 1 year of implementation compared to rates before the intervention shows a 92% decrease in hospitalizations, 61% decrease in emergency department visits, and 87% decrease in unscheduled office visits for asthma. With greater funding in the future, we can project even greater results. In conclusion, results suggest funding of asthma education and improved environmental conditions was associated to the overall improved individual level of health conditions and reduced the health disparities among those nationally at a federal, state, and local level. Thank you for listening, and this concludes my presentation on the CDC's NACP. Hope you enjoyed it. The reference page does hold all the resources I used throughout this presentation.